there we go. Okay, so our chief complaint is a 67-year-old male with previously treated esophageal squamous cell carcinoma who is presenting with lethargy and confusion. So the history of the presenting illness for this patient, as I mentioned, 67 years old. He was presenting with generalized body ache and fatigue for the past 3 weeks and acute onset altered mental status, which started 3 days ago. It was reported that the patient was experiencing diffuse body pain, which was also associated with new subcutaneous nodules located on his scalp, back, and buttocks that rapidly progressed over several days. This prompted a visit to his PCP on the 9th of July, where he was prescribed hydromorphone 1 to 2 milligrams Q4 hours PRN for presumed cancer pain. The patient's wife gave a little bit more details, and she said that he became significantly more altered and sluggish after he began taking the hydromorphone. And he was described as being lethargic and at times appeared excessively confused and agitated. On the 12th of July, he was walking his dog just in front of his apartment and experienced a fall forward onto his knees and elbows, arms, and hands, did not lose consciousness. He was unable to get up on his own and was subsequently brought to the hospital. So that's our HPIs. Does anyone want some additional information before I move on?
So I guess at this point, if anyone wants to post in the chat based on what Raj has said, do you have any other questions you want to know about this history to kind of help you decide on maybe what might be going on with this patient? I know, Raj, you said on 7/12 is when he had this fall. Was 7/12 actually when he presented to the hospital as well, or was it the next day?
He came on the 12th as well.
So Darren's just asking about the cancer history, I guess maybe his diagnosis, when that was diagnosed, and what treatment he's had.
So he had a pretty extensive cancer treatment course. He was diagnosed, I believe it was 2019 was the initial diagnosis, if I'm not mistaken. I do have a whole history of the oncology, which I didn't put into this afternoon report. But he was diagnosed with both, I'll get into that a little bit more on his treatments, but he was diagnosed, I believe, in 2019, and he was treated with both radiation and chemotherapy. In May of 2021, he had an EGD done, which showed no active disease.
And any other questions? I guess you have this middle-aged gentleman with this cancer history with lethargy, confusion, seems to have ongoing treatment for his malignancy, and then also had this hydromorphone prescription. Anything else that you would ask or want to know about the history? So Carla's asking, what medications does he take?
Yeah, so I can move on to the longitudinal history that has all the medications that he's taking. So here's some of his past medical history. Hypertension, coronary artery disease. He had a PCI in 2014 and he had 3 stents placed. GERD, he had a fundoplication in 2000. He also had PE with DVT in August 2020. And his cancer, I was mistaken, it wasn't 2019, but it was from April 2020 till August 2020. So he had chemotherapy and radiation. And then, as I mentioned, in May of 21, he has an EGD that was negative for recurrent disease. His course was pretty complicated. He did have radiation-induced esophagitis, which required a J2 placement, which was between September 2020 till March 21. He also had esophageal stenosis. He had it dilated twice on the January 21 and May 21. And he had a jejunocutaneous fistula after the J-tube, and that was closed on June 21st, 2021. I mentioned some of his past surgical history. In regards to his family history, his mother has a history of heart disease, father heart disease. And in regards to his social history, he was a prior smoker, 1 pack per day from 1974 to 2014. And he was a previous social drinker, no longer drinking. These were the medications he was on at home before presentation. As I mentioned, the hydromorphone, 1 to 2 milligrams Q4 hour PRN. Unclear how much he had taken since the time he was prescribed till his presentation. He's also taking carvedilol, clopidogrel, atorvastatin, omeprazole, folic acid, and zinc sulfate with no drug allergies. So upon review of systems, it was positive for fatigue, weakness. He had decreased appetite, unintentional weight loss, generalized body pain, abdominal pain, constipation, difficulty urinating, and skin changes. He didn't have any dizziness, headache, or vision changes, no nausea or vomiting, no chest pain, no shortness of breath, cough, or hearing loss, no fever or chills either, and no history of sick contacts.
And I guess one thing that Raj kind of covered quite well, especially on the review systems with a patient like this, is also looking for like infectious signs or symptoms in a patient like this. Given that they're elderly, immunocompromised, you definitely, and they're coming in altered, you want to ask about fevers, chills, any infectious symptoms.
Okay. So physical exam, this was the initial physical exam taken from the ED. This patient was, so I didn't do the H&P, but this patient was on my team after he got placed onto a team. So initially he had a BP of 106/74. He was slightly tachycardic at 109, no fever, respiratory rate of 17, and his SpO2 on room air was noted to be 92%. Subsequently, his SpO2 was in the upper 90s after that initial encounter in the ED. Additionally, just to mention, I know I mentioned that he had the altered mental status, but per the H&P, this patient was awake and alert ×3, person, place, and time. But when he was on the floors with our team, he was probably ANO ×2 and very agitated and confused. The rest of the physical exam was rather unremarkable. He did have some epigastric tenderness on deep palpation. And then he had the subcutaneous skin nodules on the scalp, left shoulder, and upper pole of the right buttock, and those were tender to palpation. There was no signs of meningitis. His neck was supple, no rigidity there, no specific joint tenderness. It was kind of, when we saw him in the ED, he did have knee joint tenderness and ankle joint tenderness, but when we saw him on the floor, it was kind of like he was just describing it as all over wherever you'd press, kind of. So those were the subcutaneous nodules that I had mentioned. Those, the one on the bottom are the two on the scalp, and the one on the top is that was on the buttock area. So does anyone want to give a shot at giving us the problem representation of what I've described so far? And if I need to go back, just let me know.
I can try. So middle-aged male with past medical history of CAD, GERD, cancer, status post-radiation and chemo, that presents with several weeks of altered mental status and concomitant skin lesions and use of hydromorphone, a new use of hydromorphone.
And I guess, how would you tie in the physical exam findings for him? So I know you said skin lesions. Anything else? I guess looking at the neuro exam, how would you summarize that?
Well, yeah, altered mental status.
Yeah, so I think he's coming in with like lethargy, confusion, or altered mental status. So you're definitely interested in the neuro exam for him, right? But what's kind of remarkable is that it's unremarkable. He seemed to be AO ×3 maybe when he came in. By the time he got to floors, maybe AO ×2. But otherwise, there was no focality on his neuro exam. So I think you would still want to summarize that maybe waxing, waning mental status, but that there's no focality would be important to know, because he's coming in and maybe altered, confused. So you're kind of trying to work through your differentials in your head. But great job. With that in mind, at this point, given the history physical that you have, What differentials are you thinking of in this patient, or what things do you have in mind to be concerned of? He's like middle-aged, has this cancer history, has like CAD, GERD as well, and also physical exam findings that he has these skin nodules, but nothing really too revealing, or nothing that kind of stands out on the physical exam. But what are your differentials in this point? If you saw this person in the emergency department, what are you thinking of? You can unmute yourself or post it in the chat. So Darren says, yeah, meds, definitely for sure. I think that's something that you would be concerned about, and something to look for is any meds. What else?
I was looking at the skin nodules and it kind of looked like almost like basal cell carcinoma, where it had like the red markings on it. What do they call it? Like there's like red, forgot the scientific term for it, but it's like those like little tiny vessels that come out of the
What's that?
on his forehead, right?
Like telling, like almost like telangiectasia's appearance.
Yeah, telangiectasia, that's what it's called. Yeah. I don't know. That could possibly be on the differential too. Lower on the totem pole.
But what else, I guess, more generally, are you thinking of in a patient like this? So drug intoxication meds. So he's taking Dilaudid as well. So you don't know if he's having maybe like a side effect of that, or any adverse reaction to that that might be causing this. What other big things do you need to think of in this patient?
Oh, just in the physical exam, did he have like constricted pupils or anything? And his respirations weren't that like low, right?
No, his respiratory rate was 17, and he had normal pupillary response.
Okay. All right.
Yeah, good point. But I guess oh, sorry, Tom.
Yep. So I was just going to say, I think, so with the opiates, right, we have to worry about constipation. He has a lot of bowel stuff going on. He's also complaining about urine while he's having difficulty peeing. So there'd be a possible component of urinary retention. Both of them can cause altered mental status alone. And then the other thing that I'm kind of thinking about besides the Mets is just he's been on like some heavy drugs for the chemo. So you always have to worry about like drug-induced lupus or something like that, right?
Yeah, those are all great points. And I see Galit is saying metabolic encephalopathy. So I think for sure, especially when you see kind of a physical exam like that, right? It's kind of his mental status is maybe waxing, waning, but there's no focality on exam. So it maybe tells you that maybe something more generalized is going on, and more of like a metabolic encephalopathy. So do you need to look more at like electrolytes, like your sodium, calcium, glucose, like kidney dysfunction, things like that, that might be causing a more generalized picture in a patient like this that's like getting chemo, so you're not really sure how that's affecting it. And then the other thing that I was thinking of, but it's not like super suggestive, but any infection, right? It could be like an immunocompromised patient, like Tom had kind of suggested, maybe like a UTI, but also like a viral meningitis. But I mean, he doesn't have any of the like photophobia, headache, things like that. But that's not to say that that's not something to also bear in mind. So what, if you saw this patient in the emergency department, what would be your initial workup that you would want to do, kind of with those things in mind that you've talked about on the differential? Or what initial workup are you going to order in the ED, or like that you would anticipate the ED would order? So Galit, yes, CBC, BMP, VBG for sure. They will show you like your electrolytes, if there's any like acidosis, anything like that to be concerned of, and a CT head for sure, I guess, for the reasons we talked about. Any like meds that you might be able to see, any like stroke, subdural hemorrhage, UTOX, but I guess we're like expecting that the UTOX is going to be positive anyway, I guess, unless there could be something else there that we're not anticipating, and would be there, and a UA, urine culture, LFTs. I think those are all a great place to start, and probably the most appropriate initial workup to get to see exactly what you're dealing with. So if you want to go ahead, Raj, and show maybe some of the results that this patient had.
Yep. So that was our problem representation, which I think you guys did a pretty good job with. So we had a CT head done pretty quickly done in the ED. There was no evidence of acute hemorrhage, infarction, or any kind of cerebral edema going on. These were his initial labs. So I know someone had mentioned a VBG with lactate, but this is pretty unremarkable. We did have a CMP completed, which was showing a mild AKI with a creatinine of 1.43. But the most significant finding was a corrected calcium of 16.8. In regards to his CBC, I mean, he did, his albumin was low as well, as I mentioned, was corrected, but the other electrolytes actually looked pretty good. In regards to his CBC, he did have a mild leukocytosis, a slight anemia as well, but his platelets looked okay. And on initial presentation, he did have a troponin of 5.195, which shot up to 6.2, and then subsequently downtrended to 5.1. There were no EKG changes.
So I'm just going to share my screen for a bit, if that's okay. So I guess in this case, we can see what's kind of most remarkable is that this patient has hypercalcemia, if I can draw. Hypercalcemia is the thing that's like obviously most remarkable and the thing that sticks out the most for this patient. So our normal calcium can fall between 8.5 to 10.5. And then you kind of have grades of severity, I guess, of hypercalcemia depending on the level that you have. So it can be mild, moderate, or severe depending on the number that you have. Sorry, I'm not sure why it's typing so slowly, but anyway, but your mild, moderate, severe, and mild hypercalcemia is usually less than 12, moderate 12 to 14, and then severe really 14 or above, which was the case for this patient, really severe hypercalcemia or hypercalcemic crisis almost. But usually when you have a patient with hypercalcemia, there's a couple of things, I guess, to do initially when you have that. So first you want to verify that it is true hypercalcemia, and this might be more appropriate in the outpatient setting. So say if you've like a one-time reading of hypercalcemia, you want to know if it's a true hypercalcemia, and because things like dehydration might cause you to have like a falsely elevated. So you do want to have a second reading that's going to verify that, especially if it's in the outpatient setting. And I guess like what Raj had touched on is the albumin correction that you need. So when we check our calcium here, we check, it's a total calcium that we have, right? So our BMP-CMP sample is our total calcium, but that's made up of the free ionized calcium and then calcium that's bound to albumin. So your albumin, but also your free and ionized. And that's what's physiologically active, and that's what you're actually most interested in. But obviously, if you have variations then in your amount of albumin, you're going to have changes in your free ionized calcium. So you want to be able to account for that. So I guess you can use MD Calc, which I feel like we all use, or you can also use like a rule of thumb. So for every decrease of albumin by 1 gram per deciliter, your calcium you can anticipate will drop by 0.8 mg per deciliter, and kind of use it that way. But when you're checking your calcium and you're verifying that it's like truly low, you obviously want to have an albumin as well then to account for any changes in that. So I guess with hypercalcemia, thinking of this patient or maybe other patients that you would have had, what signs and symptoms do you see or do you expect to see in patients presenting with hypercalcemia, even if it's like mild, moderate, or severe? So you can feel free to post in the chat kind of what are your signs and symptoms that you're looking for. Yeah, so constipation, abdominal pain. So I guess like the mnemonic was like bones, moans, stones, or all of those. Yeah, so Kruti put that in. That's what I remember too. So I guess bones, any like bone pain, so if you have like bone resorption and things like that. So constipation, so abdominal symptoms, so you can have constipation is the main one. But also you can see like peptic ulcer disease, pancreatitis, but not as commonly as constipation, and psychiatric overtones. So neuropsych, it seems to be like very broad, very like almost non-specific sometimes, right? It can be like fatigue, irritability, and progressing all the way to, like you saw in this patient, like he's coming in with like lethargy, having this waxing, waning mental status, and if it's very severe, like even like having patient being comatose. So bones, and then the other one, stones. So renal complications would be the main one. So renal stones, but you can kind of have like a graded presentation for that as well. So it can start as like polyuria, and then you can progress to developing like renal stones and renal insufficiency and things like that. So they're the main, I guess, signs and symptoms. And I think depending on the severity of the hypercalcemia, you can kind of see like mild, moderate, severe presentation of symptoms as a result. So I guess the other thing, thinking of this patient, but also other patients, what causes come to mind when you think of causes of hypercalcemia? Both like inpatient, outpatient, anything. Feel free to, again, post in the chat. So malignancy, yeah, so hyperparathyroidism. So those two are by far the ones that cause it the most. So like primary hyperparathyroidism and hypercalcemia of malignancy, primary hyperparathyroidism and then hypercalcemia of malignancy, they make up something like 90% of causes of this. So both of those are your most likely ones that you look for. And then your hypercalcemia of malignancy can present like a few different ways as well. So I guess what malignancies come to mind when you think of hypercalcemia of malignancy? So I know this patient, we had like a SCC of the esophagus. So lung cancer, renal, exactly. So, and I guess Darren kind of touched on it. There's like a few different mechanisms that you get for hypercalcemia of malignancy. So you get parathyroid hormone related peptide, which is by far the most common. And that's one that you see like in your squamous cell carcinomas and also solid malignancy. So Darren had touched on it, and also Omar, lung cancer, renal, breast cancer is also another one. So your squames and also solid malignancies can be seen with this. And then the other ones can be like if you've osteolytic lesions, so like your multiple myeloma causing osteolytic lesions can be another way. And then the other one is like a vitamin D induced one. So if you have like a lymphoma causing like production of like the 1,2,5 hydroxy vitamin D, that can be another one. So those are kind of your mechanisms of hypercalcemia of malignancy, and I guess to be aware of the cancers that cause it and the mechanisms for that. But both of these here will account for like 90% of your hypercalcemia causes. So I guess kind of focusing more, because I feel like we're used to seeing hypercalcemia of malignancy, especially on the inpatient side at West. But depending on where you're seeing the patient can really point towards like different causes and different management. So we said that common causes were like primary hyperparathyroidism and also hypercalcemia of malignancy. But looking at primary hyperparathyroidism, it's like a pretty common condition that you see, usually outpatient. And it's obviously you see high calcium and you verify that, you've corrected for your albumin, you verify that it's truly elevated. And you're checking your PTH then. So when you see high calcium, we said like the most common causes were primary hyperparathyroidism and then hypercalcemia of malignancy. So the first thing you're going to check is a PTH to see which pathway you go down. And then obviously if you have a high PTH and a high calcium, that's going to indicate primary hyperparathyroidism. Your normal range for PTH is from like 10 to 65, I think it's picograms per mil. So obviously if it's above 65, it's going to point towards overproduction of PTH. But also even if you've like inappropriately normal PTH, that's going to indicate like be suggestive of the same. The reason being, if you have high calcium, you really expect your PTH to be switched off unless it's like pathologically mediated by that. So if it's inappropriately normal, like greater than 20, that would still point towards a primary hyperparathyroidism in a patient like this. And I guess very different to the way Raj's patient presented, these patients, it can often be like an incidental finding where you pick this up. This is why you're like repeating the lab. It can be very mild, like you're talking calcium like less than 12, and they can be asymptomatic. So again, incidental where you don't expect it. And you're usually seeing these people in the outpatient setting where you're detecting it. And I guess the mechanisms for this, like it can be one single solitary parathyroid adenoma. It can be multiglandular. But also very rarely, but something to keep in mind, it can be a parathyroid cancer as well in these patients, which is why a physical exam is really important in that scenario, examining the neck to see if you find any hard mass. It is rare, but something that you do need to keep in mind. And really when you see these patients outpatient and do kind of major diagnosis of primary hyperparathyroidism, the only definitive treatment is surgery. So really your only questions are if you're going to proceed with surgery or monitor the patient, because not everyone has to go for surgery depending on how they present. So really knowing like when surgery is indicated and when you should monitor these patients. So when you proceed with surgery, so if they're symptomatic, you would proceed with surgery in those patients or refer them for surgery. If they're asymptomatic, it's not as straightforward. So if they're asymptomatic, what you're looking for then is if they've developed any complications of the high calcium, or maybe if they've any specific indications for surgery. And indications would be if their age is less than 50. And I think that's more so just to do with like having a younger patient and how reasonable it is to like monitor them yearly versus just proceeding with surgery. So I think that's why age is probably one of the ones there. And complications you look for is kind of related to the signs and symptoms we talked about. So if there's any renal dysfunction, that will be a reason to refer for surgery. Or if you've any renal stones, maybe they're like not symptomatic with those, but you detect them on imaging, or they have like high urinary calcium. So if their urinary calcium is high, that's going to tell you that they're at much higher risk for developing kidney stones or complications that way. So that would be another way. Or if you have any evidence of osteoporosis, so you get your DEXA scan and they have osteoporosis, right? They might not be symptomatic for that, but that's another reason. And also if the calcium is like more than 1 above the upper limit of normal. So if we're saying like 10.5 is ours, if their calcium is above 11.5, that's another indication for these patients. So I guess it is just important to know in the outpatient setting, and when you've like detected and diagnosed your primary hyperparathyroidism, like when do you refer them for surgery and when do you monitor them? And I guess if you are going to monitor them, what does that look like? So when you know your complications or your indications, your monitoring has to do with that then, right? So you want to follow your calcium, and that's usually every year. You want to follow your creatinine, again, that's every year, because you want to know if they're going to develop any renal dysfunction. And you do a DEXA scan every 1 to 2 years, and that's monitoring your like bone density. But otherwise, there is no treatment for it. You're just monitoring for complications in these patients and doing management, like, you know, removing any medications that might be exacerbating or making anything worse, and making sure they keep hydrated and things like that. So I guess that's one way that I feel like we're used to seeing a lot of like hypercalcemia inpatient and kind of know how to manage that, but actually like hyperparathyroidism is like very common outpatient, and I guess knowing how to manage and treat those patients like immediately and I guess longitudinally. And then I guess the other umbrella that we have is the hypercalcemia of malignancy. So we went through like the different arms of that, like the different mechanisms, and I think Raj will go through a bit more like how to recognize when someone presents like with severe hypercalcemia and kind of the immediate treatment that you need to do for those patients, the core components of that. But I will save that for Raj to go through with you guys. So whenever you want to start sharing your screen and maybe present the remaining data for this patient.
Sure.
I would just say that's why it's important when you're in the outpatient office, you don't ignore those mildly high calciums, because oftentimes when we finally look into it, we look back and we see that people have actually had them mildly elevated for several years and no one has investigated it.
Okay, so I think we kind of went over the differentials already. So obviously hypercalcemia of malignancy, hyperparathyroidism, and then one of the things is the granulomatous disorders such as sarcoidosis, that excessive vitamin D production. So this is the approach to hypercalcemia. I think Jackie went through it pretty thoroughly, so I won't spend too much time. But one of the things to note is that if the patient is symptomatic and you're witnessing complications and that serum calcium is greater than 14, then you want to initiate treatment immediately, which is going to consist of intravenous fluids and calcitonin. I'll talk about that a bit more. But if they're not symptomatic, there aren't really complications and that calcium isn't greater than 14, then that's when you can start to initiate that further workup. First thing being checking that intact PTH level. Obviously, if it's elevated, then you're most likely thinking primary hyperparathyroidism. And as Jackie mentioned, the normal or minimal elevation, it's still most likely primary hyperparathyroidism. You could consider familial hypocalciuric hypercalcemia, but that's extremely rare. And then, of course, the low or low normal end, that's when you want to start thinking about hypercalcemia of malignancy or the granulomatous disorders. So some of the additional investigations that we got for this patient, we did get that PTH intact, which was showing it was a low level of 6. The PTH-RP was below 2, so that was within normal limits. Ionized calcium was also elevated at 9.5. And his calcitriol was 11.9, and that was on the low end. So we also got an MRI of the brain, and this was significant for these enhancing marrow replacement lesions. So this, you can kind of see them right here. If you can see my mouse, over here, there as well. So this is most consistent with osseous metastatic disease. As I mentioned, the subcutaneous nodules earlier, those were biopsied, and that did show a squamous cell carcinoma, which was invasive and extending to the base of the specimen. And just a brief kind of hospital course. So he was severely hypercalcemic. He had a mild hypokalemia and a mild AKI. He was treated with fluids and zoldronic acid. CT head was unremarkable, and he was admitted for severe hypercalcemia. He was treated with continuous IV fluids, received denosumab. When we reached out to endocrinology, they were actually consulted at the time of admission. He was found to have elevated troponin, which he was medically treated for ACS with Plavix and aspirin. Did not have any changes on EKG, and echo was done, and that was unremarkable. And oncology was following the patient throughout his admission. So he had the workup was significant for hypercalcemia of malignancy. So the illness script for hypercalcemia of malignancy, as we all mentioned earlier, it's associated with numerous cancers, but most commonly with breast, renal, and lung cancer and multiple myeloma. Some of the signs and symptoms, it could be broad, as everyone knows, the bones, stones, groans, and psychiatric overtones. Those are the most common findings. But in regards to the neuro, you could have that decreased concentration, fatigue, lethargy, stupor, coma, even anorexia, constipation, nausea, vomiting, pancreatitis, peptic ulcer disease when it comes to GI symptoms, musculoskeletal weakness, bone pain, osteopenia, osteoporosis, cardio, you can have shortening of the QT interval, bradycardia, and hypertension. And then there's numerous renal manifestations, hypercalcemia, not only malignancy, but hypercalcemia in general. Polyuria, polydipsia, nephrolithiasis, calcinosis, a distal RTA, and acute and chronic renal insufficiency. So as we kind of went through already, so tumor secretion of parathyroid hormone-related peptide is the most common cause of hypercalcemia of malignancy. But in this patient, we had osteolytic metastasis, and this is going to lead to release of osteoclast activating factors, as well as inflammatory cytokines, and that's going to lead to the hypercalcemia. You could also have tumor production of calcitriol. This is very rare and unlikely, but that could lead to hypercalcemia of malignancy. But the two most common ones are going to be that PTH-RP and osteolytic metastasis. So it's important to initiate immediate treatment when the patient's symptomatic or calcium is greater than 14. The first thing you want to do is start with isotonic saline. This is going to help with urinary excretion, and it's also going to replete intravascular volume. When someone is presenting with hypercalcemia of malignancy, they're usually kind of coming in a decompensated state already. They haven't been eating, they have decreased appetite. It's kind of happens in an acute fashion, so they haven't been consuming anything orally. So you're excreting that calcium, and you're also repleting some volume loss that's been occurring. You could start with calcitonin. This is one of the first treatments. You start with isotonic saline and calcitonin. And what that's going to do is going to interfere with the osteoclast function, and it's going to promote urinary excretion as well. You can do zoledronic acid as a bisphosphonate, but that's going to be contraindicated with a patient with an AKI. And then you could also use denosumab, which is going to inhibit rank L, and that's going to inhibit bone reabsorption. A little bit more about the treatment. I think that's really helpful for us when we have to do an admission for a patient coming in. The only thing we have is that hypercalcemia in the labs. If we see it's super severe and they're symptomatic, we can start isotonic saline at a rate of 200 to 300 mLs per hour. And then you want to adjust that rate and maintain a urine output at 100 to 150 mLs per hour. Calcitonin should be given when you are treating for severe hypercalcemia. This patient did not receive calcitonin in the ED, but the way you would do it is you'd give 4 international units per kilogram initially. You're going to reassess the calcium in 4 to 6 hours. If there is a response, you're seeing response with calcium decreasing, you can then repeat calcitonin every 6 to 12 hours, but you want to limit it to 24 to 48 hours due to the risk of tachyphylaxis. So the response thing was kind of interesting to me. Typically, you don't know if that response is from the calcitonin or the intravenous fluids. So you imagine that if you're starting isotonic saline at that rate, you will see some sort of response in the calcium. But if you don't see any response, it's you shouldn't give that calcitonin again. It means that person isn't sensitive to calcitonin, and you would just be wasting calcitonin that wouldn't be having any effect on the patient. So then you could also do zoledronic acid if the isotonic saline and calcitonin aren't giving a response. You could do 4 milligrams IV over 15 minutes. You want to avoid this in patients with severe renal failure. And then if zoledronic acid is contraindicated due to that, you can use denosumab. And that would obviously, a lot of these are going to require endocrine and oncology approval. I believe calcitonin can also be approved by nephrology, but I'm not 100% sure. So some of the take-home points, when a patient's coming in, you want to establish the severity. As Jackie mentioned, you could have mild, moderate, or severe. Greater than 14, of course, would be the severe. You want to look for the symptom onset. If it was acute in onset and the patient is symptomatic and the hypercalcemia is severe, it should raise concern for hypercalcemia of malignancy. You typically won't see these patients presenting to the outpatient setting because of how severe and acute it happens. They will usually be coming into the ED. So it's really important to notice that because you can do that really quickly. So next take-home point would be establishing the most likely etiology of hypercalcemia. And this can actually be done really quickly during the initial evaluation. Just based on that little flow sheet, you would just get the intact parathyroid hormone, you would assess that level, and right away you can have an idea whether this is primary hyperparathyroidism or hypercalcemia of malignancy or something else. Once again, if it is primary hyperparathyroidism, it's more likely going to be seen in that outpatient setting. And then the third take-home point, the hypercalcemia of malignancy can have multiple mechanisms. It's always important to keep that in mind. Just if you don't see parathyroid hormone-related peptide, it does not mean that it's not hypercalcemia of malignancy. You want to obviously take into account osseous metastasis and that production of calcitonin or calcitriol. And if anyone has questions, I'd be happy to take them.
Thank you so much, Raj, for a great presentation and a great case. Dr. Andrilli actually posted a question in the chat regarding what was the purpose of getting an ionized calcium in this patient.
So my understanding is the ionized calcium was just kind of, it was more of a confirmation of the severity of the hypercalcemia. I know we did the calcium correction, but from my reading, you just do that to confirm the level of hypercalcemia. I don't know if it actually changes the management or would actually change how you would classify the severity, because the ionized isn't what's used for the severity ranking.
So then my question would be, is it absolutely necessary?
I don't think it is absolutely necessary, no.
Right, because we do a lot of things just because we've always done them.
Yeah.
Right? But ionized calcium is more difficult to get. It's more expensive, you know, but probably your attending tells you to get it, but it doesn't really change a lot of things unless someone has chronic kidney disease or something. So I think you would avoid getting it, especially sometimes I see people ordering in the outpatient office where it's really difficult to get and probably not even reliable. So I think you just always want to remember when you're ordering things, because on the inpatient side, we order a lot just because it's easy to do, but we want to hold ourselves back on things that don't really change anything, because everything costs money.
Yeah.
Takes up lab time, etc. The patient's on the other side of the needle, etc. So unless someone else can give me a good reason why we do it, especially when someone has a calcium of 16.8. Any takers out there?
I don't think there is for like what we do. The only time I've heard they do it a lot is, not a lot, but in the operating room they might do it, but that's because they can analyze it like straight away, and they've like lots of other stuff that affects their readings, right? If they're giving blood and they've citrate. But I guess in our like outpatient, it seems like the ionized really isn't that good to use, and actually is like bad to use because, you know, the sample's hanging around. But I think inpatient in our patients, probably the total is more standardized and more useful, and you'll get the result quicker, and it's numbers that you're used to dealing with and managing.
Exactly. And transfusions, right, because there's citrate in this transfusions. So I would just say, try not to order it. And if you do, don't keep repeating it. But otherwise, great case. Not for him, but.
Yeah. Unfortunately, this patient did, after discharge, he was discharged on the 23rd of July. He did present again a week later for hemoptysis. He was discharged then, and he was admitted again in August for some more complications. I don't know how he's doing now, but. Anybody else have some questions?
So I guess Tom just asked any further workup events during his hospitalization from the cardiac perspective, given his troponin. I know you kind of touched on the elevated troponin, not sure why they checked it, but I guess it started trending up then.
Yeah, so I think the elevated troponin, initially he was treated with the high dose of aspirin and Plavix, and the EKG did not show any changes. It was actually a normal EKG. Echo was unremarkable. Cardiology was following him throughout the entire case until he was discharged, and they were, because of his history of the PCI in the past, they just recommended outpatient ischemic workup if indicated, but we didn't really do anything else from a cardiac perspective.
And I see Angad posted some article. I'm not sure what that's about. Maybe, oh, things they do for Angad's question project.
I can remove myself. So calculating corrected calcium level based on albumin is also, it's kind of a thing we've been doing for ages, but in studies it's shown that uncorrected calcium levels have correlated with the ionized calcium levels more than corrected, because there's some physiological mechanisms in which if you have hypoalbuminemia, even if you have low albumin levels, the amount of calcium being bound to albumin increases. So correcting it for the albumin level may sometimes make some mild cases of hypocalcemia appear as normocalcemic and then deny people treatment. So correcting for albumin is something we actually overdo and shouldn't be doing as often.
So there's lots of things we do just because we always have, and you want to fight that urge. It's like don't ever say Hohmann sign.